Thanks a lot for being here. This is the second seminar of this semester, and today we have the honor to have, my God, I don't know how to pronounce very well.
Siew.
Ling, exactly.
Correct.
Who is an assistant professor at Monash University in Australia. So she's gonna talk today about health externalities to labor productivity and optimal policies with endogenous fertility, labor, and longevity. So as usual, we have 1 hour. You can ask questions during the talk. And thanks a lot for being here. It's an honor for us to having you here, and the floor is yours.
Thank you. Good morning, everyone. Thank you for coming. So it is also my great pleasure to have the opportunity to share my research with all of you. Sorry that the title of this talk is very long, but I do not know how to shorten it because I feel that this title captures what I really want to talk about today. So this is a joint work with Zhang at Chongqing University and National University of Singapore. Okay, as it is well recognized in the literature, health is an important form of general human capital. So we say it's general human capital because health is different from education. So health and education are going to contribute to human capital accumulation, but this paper is going to focus on health only. Okay, health is important because it's going to determine our capabilities and well-being in general, and also labor's productivity in particular. And therefore, achieving good health for all actually is an ongoing call by the United Nations to achieve the Sustainable Development Goals. However, the challenge of achieving good health for all is market failure. Okay, it's market failure arising from health externalities. I will give examples here about what are these health externalities mean. Okay, so these health externalities mean that the external cost of poor health or the external benefit of improved health are massive. Empirical evidence, in fact, shows that, for example, infectious diseases like COVID-19 lead to adverse macro effects. That is going to cause the output produced to drop, cause the workplace productivity losses, and also mortality that is not recognized by individuals. Okay, this is the external cost of poor health. For example, if there's a certain group of people, they do not want to get injection, or they do not want to put up their face mask, this is going to cause other people to get infected as well. And the external benefits of improved health, for example, will be the influenza vaccination. This can effectively reduce mortality and also work absences. So this is the external benefit of improved health that is not internalized by individuals. There is also empirical evidence that shows workers' utilization of preventive healthcare services increases with the share of work peers utilizing the services. For example, if at Monash, my colleagues, they went for health checkup every week, or not every week, too much, every year. So I tend to go as well. So it's more of the peer effect. So this is also externality. Okay, because of this, we see that this market failure in health is actually quite common. Okay? Yet it is unclear how these health externalities to labor productivity affect health spending, longevity, savings, and fertility, which are all important determinants of output. It is also unclear whether social policies like public health insurance or private health insurance through employer-based health insurance, so EHI is popular in the US, and how taxes can internalize all these health externalities. So this paper is really about fiscal policies. Okay.
And do we care here about the kind of health subsidies, whether they're going to be for preventive care or they're going to be for more directed towards care once you actually fallen in?
Yes. So here the health spending include everything that are preventive, curative, that actually improve the health status. So the objective of this paper is to develop and calibrate a life cycle dynastic model with endogenous fertility, labor, and longevity to answer those questions.
And sorry again to bother you, but just one more question.
No problem.
To clarify, like, so, you know, at least when you think about health expenditure in let's say low income settings, right? You know, one of the concerns is that, you know, people often tend to have very high curative expenditures because of course then they're left with no course of action but to spend the money to get cured, whereas preventive healthcare seems to lag behind, you know. So from a fiscal or from an insurance design aspect, would we like to think about there being a distinction in where the government should be putting its dollar in some sense?
I think this is a good question. So differentiating the health spending for preventive or curative will be something that's interesting as an extension, but in this paper, we do not differentiate, but this is really something that is interesting. Yes.
Sorry, so just to build on that point, curative care also in general is more expensive than preventive care.
Definitely, yes.
So,
and also, you can think of for preventive, that will be more, well, we get more external benefit from it, right? But for curative, then the external benefit will be lower and more expensive. So of course, this will have different implications, definitely.
And just also clarification question. We're gonna be looking at total health expenditure, or we're gonna make the distinction between public and out-of-pocket expenditure?
We will look at differently.
Okay.
We will look at the public health subsidies, and then we also look at the total.
Okay.
Okay, so this is what. So this life cycle dynastic model, maybe you may not be very familiar with this type of model, but life cycle means is the overlapping generations model. For dynastic model, it means that the parents are altruistic. So the family members, they care about the welfare. So they will maximize the family members, all the family members will maximize the welfare of their family rather than the individual utility function. So this is what is meant by dynastic model. Okay, so the ideas of this paper is that we assume health spending. You can think of health spending as just like health investment. So including preventive and curative. So it's going to improve the health status and also labor productivity and longevity. This longevity refers to the life expectancy, OH longevity. This is in line with empirical evidence. So health externalities to labor productivity occur in this paper because of the following assumptions that we make here. First, individuals' health, we assume that individuals' health status is private information. So firms, they do not know whether worker A is healthier, how much health investment this worker A has invested. So no private information. So this health investment by individual workers is not perfectly observed by firms. Okay, so this is, I think it's reasonable assumption because health status is private, right? Therefore, when healthier and more productive workers improve the average labor productivity at workplaces, firms lack the information to reward the workers. So this is what is meant by health externalities. So workers underinvest in their health. This leads to low labor productivity as a direct impact. So this is what is meant by health externalities to labor productivity. Okay, so this therefore suggests policy intervention because the laissez-faire definitely is not efficient due to these health externalities. Okay, so workers underinvest in their health because workers are not rewarded by the health investment that increase the average labor productivity at workplaces. In practice, we observe that workers are covered by universal public health insurance financed by taxes in many countries, including Malaysia, right? Also in Australia. While most workers in the US is very special. US, they do not have universal public health insurance. Most workers are covered by this private health insurance called EHI, employer-based health insurance. So the question here is that whether these public or private health subsidies can internalize the health externalities and achieve the social optimum. If yes, then how, right? We want to look at the mechanism. Okay, so we theoretically find that the health externalities is going to lead to underinvestment in health and therefore lead to lower labor productivity at workplaces. And this is going to cause more negative impacts when we have endogenous labor supply, endogenous longevity, endogenous fertility, right? So these negative effects will be when labor has lower productivity, they will supply less labor because it's less rewarding. So they will lower down their labor supply time. And this lead to also, because underinvestment in health is negatively affected the OH longevity will be lower. And then the wage rate and the interest rate will also be lower because of lower labor productivity. So lower labor productivity is going to reduce the market wage rate and also reduce the real interest rate. And therefore, lower real interest rate is going to lead to lower savings. Lower savings and lower labor productivity and low labor supply is going to cause the output per young worker to be lower, but it's going to cause fertility to be higher compared to the social optimal levels because wage rate is lower, and therefore the time cost of raising a child is lower, and this leads to higher fertility rate compared to the social optimal level.
But productivity is measurable, is perfectly observable in your model now.
In the aggregate level, yes, it's
Okay.
observable.
Mhm.
Yes.
But not at an individual level.
Not
Again,
at
it's
the individual level. Yes. We find that appropriate public or private health subsidies combined with appropriate taxes can internalize the externality and achieve the social optimum. So the intuition is this. Why is that health subsidies are important? Because either public or private health subsidies, this can reduce the cost of health investment, and therefore this increase health spending and health investment. And since health investment rises, this improve health status and therefore improve labor productivity, labor supply, and OH longevity, and makes children more expensive. So therefore, this is going to reduce fertility.
So just a question on, so if you replace the health there with like any, a broader set of human capital, let's say education, would the same line of reasonings and then the theoretical predictions be the same? Or
no, not the same. If it is education, then there will be no direct effect from education to health investment. And then no effect on the longevity, maybe no direct effect, but the indirect effect possibly will occur, but the mechanism will be different. The quantitative effect will be different. Yeah, and also it's true that when education level is higher, fertility rate is also going to go down, but it's true the education cost rather than the health cost. Here is really the direct impact is really the health investment linked to labor productivity directly and then the longevity directly. Yes, but the effects should also happen when there is education. Just the mechanism will be a bit different and the quantitative effect will be different.
So in the context of your model, then if I was to think about, so if countries were today to improve health provisions, say by expanding the kind of healthcare they have, for instance, in the United States, not touching childcare policies, you would in fact expect further declines in fertility then, according to your model?
According to my model, yes. If there is health externalities.
But exactly. I mean, we are assuming we are in a world with health externalities, right? Although we might assume in a lot of these industrialized high-income settings, people are already saying that that fertility levels are already below socially optimum levels, right? So
that's another problem. This is really the preference for having children. So this our model cannot tackle.
Yeah, exactly.
The social norm, right? And also,
whatever there might be structural. So I'm just saying that if you hold the constant, the structural or cultural values today and just expand healthcare, we would in fact expect that in all these high income nations that we observe even more greater declines in fertility there.
Yes, correct. But we need this fertility to go down if looking at these health externalities, because with these health externalities, the efficiency will cause the fertility rate to be higher than the social optimum, this part. Here. That is, these health externalities is going to cause this fertility to be higher than the social optimal level. So even though we know that now fertility rate is already very low, but in my model, with these health externalities, this fertility, the benchmark fertility rate is actually not optimal.
Mhm.
We need to go down more due to these health externalities. Yes.
How do we think of, maybe you covered this, sorry.
Yeah, no problem.
How do we think about these subsidies? Are we
Mm.
talking about subsidies in the traditional sense of affecting prices? Or could they take any form? Like,
Yes, affecting relative price.
But could it be like, would government provision of health services, let's say, like, like many countries do,
Yeah,
have the
so
same impact in
yeah.
the model?
yes, in my model, I have these public health subsidies, right? So these public health subsidies is, I treat this universal public health insurance as universal public health subsidies. So for example, you go to the public hospital, you may spend $2 or $3. The rest will be covered by the government. So this will be the public subsidies. So this public or private health subsidies is going to change the relative price of health spending versus other consumption goods, right? And also it's going to change the relative price of health investment and the price of children as well,
Mhm.
right?
Yeah.
So all these subsidies is going to change the relative price.
But
There's a
in the-
substitution effect.
But sorry, in the model it's like a transfers, or in the model will appear as a subsidy to the price of?
No, it's not a direct transfer.
Okay.
It's going to affect the
the
budget
price.
constraint
Okay,
of the workers because they need to pay taxes to
Okay.
finance these subsidies, right? Okay, so sorry, yeah. So I find that appropriate public or private health subsidies combined with appropriate taxes can internalize the externalities and achieve the social optimum. The intuition for health subsidies are already explained. And then if there are no taxes, under the case that we have private health subsidies, we do not achieve social optimum. Because if there's only health subsidies, we are going to have much lower fertility rate than the social optimum. Okay, because this health insurance is going to cause the wage rate to go up because labor are more productive now. So this health subsidies is going to increase the wage rate and cause the time cost of raising a child to go up substantially, that reduce this fertility a lot that is below the social optimum level. So we need taxes to counterbalance the negative effect of health subsidies on fertility to achieve the social optimum level, because these taxes is going to reduce the cost of raising a child. So you can think of if you pay labor income tax, right? This reduce your after-tax wage income. This reduce the time cost of raising a child. So therefore, it will have a negative effect compared with the effect of health subsidies on fertility. So therefore, health subsidies combined with taxes, they have different or opposing effects that can lead us to achieve the optimal rates. So we need this opposing effect.
And what about the financial costs of raising a child? How do they come into? So I can see what
Yes,
completely
later
see
come.
that they will come in because also a sharp increase in wages. You can imagine makes it much more cheaper for me to have a child now because the child comes with a bundle of costs, right?
Yes.
So they're pulling me in two opposite directions, like you said. No, so one is the income and one is the substitution effect, right?
Yes.
But what determines what outweighs it?
In our model, it's always the substitution effect that
Outweighs the.
The income effect usually will be stronger when you have cash transfer, that kind of thing. But if this is the labor income tax, this type of distortions is going to cause the substitution effect dominates. Yeah. Okay, then for the quantitative results, we find that based on calibration to Australia and US data, so we compare these two because Australia has universal public health insurance and US does not have universal public health insurance. So then we find that both benchmark economies have higher fertility, but lower capital per young worker, lower labor supply, lower output per young worker, compared with their laissez-faire and the social optimal levels. This is because we assume that these benchmark economies have health externalities. Okay, so then we quantitatively figure out how to optimally finance health subsidies through income taxes only. Because in reality, these health subsidies are mainly financed by income taxes, and income taxes are the major tax revenues of the government. So we look at how income taxes can optimally finance health subsidies. So what we found is that Australia with universal public health requires higher optimal health subsidies and higher labor income taxes for young than old workers. So our result actually shows that the age-specific tax rates are very important. Okay, so different age groups of people, they should pay different tax rates. So in our model, if this country has universal public health, then the young workers, they are going to receive more health subsidies because they are more productive. But they also need to pay more taxes because they are receiving more benefits. Okay, so this is what we found for the Australia case. But for US will be different. US has public health for elderly and the employer-based health insurance for the young workers. In this case, it requires higher optimal health subsidies for young than old workers. That is, the private health subsidies should be also higher for the young than the public health subsidies for the old. Same reason, because young workers, they are more productive. But now, the old workers need to pay more income taxes because it is the old workers that receive the public health subsidies. So you see the difference here?
Yeah, I just have a question about that. Like, so the young workers are more productive, but that productivity is not reflected in higher salaries relative to the old people, right?
No, also will be reflected in the higher wages. And because for this, for US case, the young workers are covered by the private health subsidies, right, under employer-based health insurance. So they are going to have higher labor productivity and therefore they receive higher wage rate. So they also need to pay more taxes, but they are going to pay less taxes in this case because they are not receiving the public health subsidies. So under this case, actually the young workers are they benefit quite a lot. That is, they receive the private health subsidies through their employers. They do not pay higher taxes because they are not the one that receive the public health subsidies.
Because in the US, you have Medicare, that's why.
Medicare is for the old workers.
That's why, I mean, it's like what US would look like, or
Correct.
like, compared to where it is now.
Yes. So the old workers will need to pay more taxes because of Medicare. So this is what our model found.
Old workers.
So we assume that the old workers, they receive the Medicare in the US, the public health subsidies.
Okay, but okay, sorry, just for clarification, but I just not got a bit confused with the term because I thought a worker in any case is receiving the employer health insurance irrespective of my age, right? Why does it matter?
Not really, because in the US, this EHI is mainly for workers above 65. So if you work longer than 65, usually they are covered by Medicare directly.
Because you can be working more than when you're 65 and the employer doesn't cover you with insurance anymore.
In the
Based
US,
on the
there is
data.
universal healthcare system for 65 plus, known as the Medicare system.
Okay.
That's tax financed by the central government.
Even if I'm working, then the employer need not provide me with the health
No,
insurance
because
anymore if I'm
covered
plus
by the
65.
government.
Okay.
They are covered by the government already. So employers do not need to cover their health insurance anymore. Yes.
One more question. When we think, so these are like, sort of efficiency outcomes, right? But
Yes,
the
efficiency
whole
outcomes.
goal of sort of government intervention in the markets for healthcare hinges on two arguments. Efficiency, like without government intervention, it wouldn't be efficient. And the other argument is redistribution, right?
Correct.
So
I do not tackle the
You're
distribution.
not talking about
Yeah.
redistribution.
It will be very complicated. If I tackle the income distribution here, for example, now I have overlapping generation models, right? I differentiate age group. So different age group, they pay different tax rate. If I also include the income distribution within the same generation, will be very complicated.
Yeah.
So it means low income, high income for the same group, that will be, then I will need to forego all the theoretical findings, only quantitative. So that's a trade-off.
In that case, that's like a heterogeneous agent.
That's right, heterogeneous agent model. That's
That's true. It makes the math very
complicated.
complicated.
And usually that kind of model can be only handled quantitatively.
I see.
Mm.
Okay.
Yes. So I will need to forgo everything about the theoretical results. But I feel that theoretical results are important because they really show the mechanisms and the intuition. Or else if you only have a model with a lot of features and only have quantitative effects, you do not know what causes what. So you just see the end results. So this is the trade-off. Okay, so we also find that when the health externalities are stronger, it means there are more external benefit of health investment, then we need higher optimal health subsidies and taxes, right? So this is intuitive. And if suppose we have an economy that has universal employer-based health insurance only, there's no public health subsidies at all, then internalizing stronger health externalities is going to increase optimal private health subsidies and optimal old age labor income tax, but reduce the optimal young age income tax. As I say, under these private health subsidies, the young workers get the most benefit. Okay.
So how is the, I guess, life cycle model? Because like, old age workers are usually not working as much. So if we are increasing the tax on old age workers, that it's not aligned with like how much they have at the moment, right? Like in terms of like consumption smoothing, that they would have to have more disposable income earlier on in their life. So why can't we think about like them paying more taxes when they're younger and then reaping the benefits in older age?
Yeah, here is because this EHI is going to increase the cost of having children substantially. So we cannot increase the optimal young age labor income tax substantially, because in that way it's going to further down the fertility rate. So we need to impose higher labor income tax on old workers rather than young workers. Because, okay, let me mention again, these private health subsidies is going to increase the cost of raising a child substantially, because this EHI is going to increase the wage rate, okay, of all workers. So, but only the young workers is going to decide how many children they want. So the old workers will not have that choice anymore. So only the young workers have that decision. So when wage rate goes up, so the young workers will have higher opportunity cost of having children, more children, right? But if we further increase their labor income tax, this is going to cause their number of children to go down even more. Then this is not efficient.
Is it assumed that the workers have perfect information, that they know that when they're older they will get higher taxes, and how would that affect?
Yeah, in your model is perfect information.
So how would that affect personal decisions when they're young? Because like they know that in the future I'll get higher taxes, so at the end it's the same, right? Like I should have the same.
Just life cycle differently. So at young age I pay less, but at old age I pay more. This I know from the point that I make my decision. So this is what I know. So this is the optimal outcome in our model. Okay, so this study, yes.
I'm a little worried about
No
the
problem.
time. It's already half of
That's
the
right,
talk.
yeah.
And we haven't seen the model, so, and we can.
Yeah, I can skip the literature.
Thank
Okay,
you.
so keep the literature. So the baseline model has infinite number of periods, and each period has 3 overlapping generations. So children, young parents, old parents. Only the young parents decide on the number of children. So we assume children do not make any economic decision. Only the young parents and old parents make decisions. So we normalize the length of young parenthood to 1, and the length of old parenthood, this is T function, is the old age longevity. This T function rises with health spending at young age, HT minus 1, and old age MT. So you can think of the old parenthood is at time T, right? So this T function is going to rise with the health investment at young age and old age, but at diminishing rates. Okay, so we further simplify our model by assuming that this old age longevity T function is also the old age labor supply. So we abstract from retirement here. Okay, so this is the household's preference for a dynastic family model. So the dynastic family derive utility over the consumption of the old parent, DT, adjusted by the old parent's longevity at OH, this T function, and also the consumption of the young member, CT, and also the number of children of the young parent. Okay, so this alpha will be the time discounting factor. In this model, it also measures the altruistic parameter. So how altruistic is the old parent towards the young parent?
Sorry, what is the difference between the alpha and the beta? Isn't the beta the discount factor?
Alpha is the time discount factor. The higher is alpha, then the savings rate will be higher, just like the time discount, the time preference.
Oh, okay.
Yeah,
okay.
yeah. So this alpha is the time preference. So higher is the alpha, the lower is the time preference. So more forward-looking. Okay. Okay, now we come to the household's budget constraints. So because now we have young parent and old parent make decisions together and they care about each other. So for young parent, we assume that there is 1 unit of time endowment for every young parent. They are going to allocate their time to child rearing, their V and T, where V is the fixed time looking after a child, is exogenous. So NT is the number of children, is a choice variable. And then the rest of the time will be working, 1 minus BNT. This young parent either receive bequest from old parent when BT greater than 0, BT is also a choice variable, or give a gift to old parent when BT is less than 0. So we allow two-way, okay, transfer. Then this young parent is going to allocate resources to his or her young age consumption CT, young age health spending HT, and then the rest for savings. So this will be the young parent's budget constraint. WT will be the wage rate. And then the old parent, you can see that this WT is the wage rate. This T function is the OH labor supply. So therefore, T times WT will be the OH labor income. So this part will be the savings plus the return. So old parent spends wage and capital income on OH consumption, DT, adjusted by the OH longevity T function, and health, right, MT at OH adjusted by the longevity. And this is just the bequest, right? Okay, so this will be the old parent's budget constraint. The production function for the final good per young worker, YT, depends positively on capital per young worker, KT, and also the average health status of the labor force given by this omega bar that is determined by the average health spending of a young worker, bar HT, and also the average health spending per old worker given by bar MT. So all the bar variable indicates the average variable. And LT will be the total labor, okay? So including the young and old workers, but normalized by the number of young workers. Oh, sorry. So this omega function increases with the average health spending. There is the average health spending per young worker and average health spending per old worker, bar MT, at diminishing rates, okay? So you can see here, you can think of this omega LT is just the effective labor supply, okay?
I'm sorry, I have a question about the average health omega. So since health has sort of a stochastic component to how the chances of you getting a disease, right? Would it be
health shock.
Yeah,
right.
Would it be better to add like a sort of stochastic variable for that?
Yeah.
Average health?
Yeah. For some other studies, they conduct quantitative analysis. They will have this health shock, but in our model, because this is deterministic, we do not include that.
Okay.
Yeah. So yes, good question. Yes, this is we abstract from that.
How reasonable is the assumption that, you know, the omega bar is going to be increasing in average health spending? Because like, I think going back to the discussion about like, you know, curative being more expensive than preventive, potentially with like the average health work of the workers are lower, then you need more curative spending, and that's actually going to increase.
So you can think it that way. If you suffer an illness, if you treat it, then it can increase your labor productivity rather than you don't treat it. So this is the intuition. Right? Okay, Okay, then we assume perfectly competitive factor markets. So firms is going to choose labor, LT, and capital, KT, to maximize profit, and therefore we solve for the equilibrium real wage and the equilibrium real interest rate. So you can see WT and RT actually increases with the average health status, but firms don't link these factor prices to workers' health investment, HT and MT, because firms cannot observe the individual level HT and MT. So due to health externalities. Okay, so this is the health externalities. So these equations just shows the market clearing conditions for capital, labor, and output. Okay. Okay, now I'm going to describe and compare the social planners problem and the laissez-faire problem to gauge the efficiency loss of health externalities in the laissez-faire. So we can compare laissez-faire and social optimum to see the efficiency loss. So the social planner, under the social optimal case, the social planner actually chooses all these choice variables here, right? Consumption of the O, health spending of the O, and this is the average health spending of the O, where the social planner can take control of. And this is the young workers' consumption, young workers' number of children. This is physical capital. This is young workers' health spending. This is the average young workers' health spending. To maximize utility subject to the feasibility by setting the individual level health spending to the average level to internalize the health externalities. So this is just follow the public finance method. And then for the laissez-faire, the dynastic family chooses everything same as social planner except the average variable. That is the average health spending. They take prices and the average health spending as given. Okay, so this is the difference. So they cannot internalize the health externalities. So therefore, this is what we found. Compare with the social optimum, the laissez-faire allocations have lower health spending because the laissez-faire economy has lower perceived return to health spending. This is going to lead to lower health spending, lower labor productivity, lower labor supply, lower longevity, lower wage and interest rate, lower savings, lower output per young worker, but higher fertility because of lower cost of child rearing when wage rate is lower. So in conclusion, we can say that laissez-faire is inefficient due to the health externalities, and this suggests policy interventions. So next, I'm going to include health insurance and taxes to see how they can internalize, okay, the externalities. So now I'm going to introduce EHI and public policies into the baseline model. That's the laissez-faire model. So now,
sorry, just a clarifying question. I mean, here, we assume that we know what is the optimal level of health, right? And because of that,
Yes.
you know where is the underinvestment.
yes.
So, I mean, that is not necessarily the case, no? So
In reality, you mean, right?
yeah, so your model can tell us like how much is, I mean, how much is good to invest in health, or maybe there is a point that is already too much? Or...
We know in this model.
Okay, okay.
Yes, perfect information.
Okay.
Yes. Okay, we assume the private health insurance market is perfectly competitive and offer an actuarially fair policy, which means that the insurance premium is just equals to the insurance coverage. So the first equation is the insurance premium per young worker equals the insurance coverage by this young worker. And the second equation is for the old workers. Okay. And this pi t is just the co-insurance rates on young health spending, and pi o will be the co-insurance rates on old health spending. So in other words, each equation just shows the actually fair health policy. Okay, insurance premium equals the insurance coverage. Okay, now the production function will need to be rewritten in a way that we need to include this health insurance into the omega function. So this sum IT plus bar HT is actually insurance coverage. This is IT is the insurance premium equals insurance coverage plus average out of pocket health insurance per young worker. So this H bar is not observable by firms, but firms can observe IT. That is the health premium. The health insurance premium is observable. And this Second component, ITO plus bar MT is the insurance coverage for the old workers plus the average out-of-pocket health spending per old worker. Okay. And the sum of this divided by the longevity adjusted by the OH longevity give us the average health spending per old worker. So the summation of this IT plus bar HT, the capital bar HT, give us the average health spending per young worker. So in other words, this function is exactly the same as the production function as before. But here is just that firms is not only choosing KT and LT, but also will choose IT and ITO as well. Okay, so the first profit function now include these two other terms, that is IT and ITO, where this lambda T is the firm's subsidy on young age health spending, because the firm is going to subsidize the workers, okay, to cover the sum of the insurance premium. And lambda TO will be the firm's subsidy on OH health spending. So the first order condition with respect to KT and LT are the same as before. So we just need to work out for two extra first order conditions. That is with respect to the insurance premium, the insurance premium for young worker and the insurance premium for old workers. So the first order condition with respect to this insurance premium solve out the optimal firm's health subsidy for young worker and for old worker. So in other words, these two extra first order conditions implies that firms can mitigate the health externalities by subsidizing workers on their health spending, right? So this is how the firms can, through EHI, can mitigate the efficiency loss of health externalities. Okay, next is to consider the public policies. So for the government spending, we consider the lump sum transfer to the young and elderly, savings subsidy, Zeta S, subsidies on health spending at young and OH, Zeta and Zeta O. And then for the taxes, we consider the young and OH labor income, TAU and TAU O respectively, consumption tax TAU C, and capital income tax TAU X. Okay, so we assume government balances its budget every period for simplicity. Of course, with all these private health insurance and public policies, the household's budget constraints will change by including all these blue terms, which are the private insurance and public policies. So you see that all this private insurance and also public policy is going to have these substitution effects, right? So it affects the budget constraint. So that dynastic family maximizes utility, subject to the budget constraints, taking prices, and also the policy instruments as given. Okay. So we theoretically find that this private health insurance coverage rates given by pi t and pi t o, pi t without the O superscript is for the young worker, okay, and the public health subsidy, Zeta and Zeta O is for O, without O is for young, increases the marginal benefit of health spending, right? Because health subsidies, either the private or the public, actually reduce the healthcare cost. So this increases the marginal benefit of health spending. Therefore, this can lead to optimal health spending for young workers and old workers. And then we also can achieve the optimal fertility rate by combining the effects of health subsidies and taxes. Because health subsidy and taxes, they have opposing effects on the marginal cost of having children. For the private health insurance, for old workers, and the public health subsidies for old workers, we see that these health subsidies for old workers, either from the health insurance or from the public health subsidies, is going to increase the productivity of old workers and therefore increase the wage rate of the old workers and lead to higher transfer from old parent to young children. So this increases the cost of child rearing. This mechanism is going to reduce fertility rate substantially. So we need the taxes to reduce the cost of child rearing such that the NT rises a little bit to achieve the optimal fertility rate. Okay, as I said, the taxes, either consumption tax or labor income tax, is going to reduce the cost of raising children. So this can increase some of the fertility rate that caused by these health subsidies. They together, if they set appropriately, they can help achieve the optimal fertility rate. So we cannot without taxes in our model. So even though it is possible to have private health insurance only, right? Because private health insurance does not need taxes to be financed. So even though in reality, it's possible that the firms offer private health insurance, but if government don't intervene to have these taxes, then the economy will not achieve social optimum. Okay, so this is our result. That is, this EHI, there is the private health insurance, need taxes, okay, to achieve social optimum with or without public health subsidies. Okay, so if there is public health subsidies, then the tax rate will be different, but they together can achieve social optimum. So taxes are really important in our model. So therefore, in sum, the theoretical findings here is that with appropriate taxes, public together with private health subsidies can coexist to achieve the social optimum relevant to the US. It's just that the government needs to set the right tax rate. Okay, and also public health subsidies. If there is only universal public health subsidies, the economy can also achieve the social optimum if the taxes are set correctly again, but the taxes will be different. This is relevant to many countries with universal public health insurance only, like Malaysia and Australia. Or if the economy only have private health subsidies through employer-based health insurance, the economy can also achieve social optimum, provided that the taxes are set at the right level. So this is relevant to health reform that introduced the universal employer health subsidies. So in sum, all these different health policies can achieve social optimum, provided that the taxes are set at the correct rate. So this is what our model found, okay?
But this is to go back to Akash's point, it's going to have very different sets of winners and losers depending upon the world we are in.
Yes, correct. So here I will provide the quantitative results in the steady state with specific functions. So we assume a Cobb-Douglas production function, and this omega is also of diminishing return in H bar and M bar, where this mu is really important. This mu measures the degree of health externalities to labor productivity. So when mu is 0, then there will be 0 degree of health externalities. So here we assume that mu is positive. Assume CRRA utility function, and then the longevity function, T function, is given here just to make sure that this longevity T function increases with H and M, but at diminishing rates. Okay?
Sorry, how do you calibrate the omega bar? Like, how do you map the data with?
Yeah, this is something that's tricky. We cannot map that. We do not have data, but we use the empirical estimate by Bloom and his co-authors.
Okay.
And what about mu? How do you calibrate mu?
I don't calibrate. I use the empirical estimate in the in one empirical paper by Bloom and his co-authors. Because Bloom, he is an expert in health economics, so he estimated a lot of this type of aggregate models. So I just borrow his estimates. So I do not calibrate myself. Okay. Yeah. So here, I look at the cross-country analysis between Australia and the US, and I calibrate key parameters to match Australia and US data between this period. So this data, including the time preference data, and then some of the preference for children, taxes, the fiscal policies, okay? And I assume Australia and US share the same value of other parameters, like the production function, the capital shares income, and also the labor share of income. I assume they share the same parameters. And I also assume that this mu, the degree of health externalities, are the same between these two countries, follows the estimates of this Bloom co-authors, where he estimates this for 133 countries. So I just take the middle range. So he found is between 6 to 12%. So I take the middle range. So it's too difficult to measure individually. So I don't have data, so I cannot measure it. So I assume that Australia and US, they have the same degree, but then I look at how taxes should adjust.
Okay.
Yeah, so this is really about fiscal policy.
So,
Yes?
sorry, how can we interpret the mu? What, 9% of what is exactly?
Yeah, this mu just 9% means that when the health status increased by 1%, this is going to increase the marginal product of health status is 9%. The marginal product of average health is 0.09.
Okay.
Sorry, so the reasonable upper and lower bounds just come from the confidence intervals directly from Bloom? Or-
Yes. But here, Bloom assumed that theta, that is the capital labor share, theta here, because I measure mu using this production function, he also used Cobb-Douglas production function. So he assumed this theta is 0.33 or 0.3. Then he got the estimate for mu between 6 to 12%. I take the middle range. And also, I also let theta equals to 0.33, consistent with the literature. Okay, so this is the observations in Australia and US. So as you can see, what is really make a striking difference is really this longevity. So as you know, US is one of the, we know that US is an OECD country, but it has the lowest OH longevity, right? So as you can see, Australia is very high. Also, the fertility rate is higher in the US. This is true based on the data. And then here we assume that the young age public health subsidy and old age public health subsidy are the same in Australia because Australia has universal public health. So they don't care about the age group. So everyone receives the same health subsidy. But in US it's different. US, only the old receive the public health subsidy. So it's 0.5. I followed one of the quantitative literature is 0.5. And then the young age public health subsidy, I assume is 0 in the US because I do not consider the mean tested health subsidy, the Medicaid, all those, because these people may not in the labor force. So I only care about workers here. And then for the old age employer-based health insurance, I assume it is 0 in the US because in the US, the EHI mainly cover the workers that are below age 65. So in our model, all workers are age 65 and above. Also, another striking difference between US and Australia will be the investment rate. So US is very low, 18% compared to Australia. So this will give different results. Wow, it's already, I don't really have enough time. Okay, so I skip this. Okay, I use this method to measure welfare. I skip this. Okay, so now I compare the equilibrium outcomes. So the first column is the social optimum. The second column is the laissez-faire. Third column is the benchmark. Okay, so as you can see that if I compare column 2 and column 3 for Australia and US, so this delta I measure the welfare change. So it means that under the laissez-faire, for Australia and US, the laissez-faire works better, right? And then under the social optimum, of course, the welfare must be higher than the laissez-faire and the benchmark. But the main thing here is that the welfare loss of taxes is greater than the welfare gain of health subsidies for the benchmark that cost the laissez-faire welfare is higher than the benchmark economies. Okay, because we know that in OECDs, the taxes are very high. So we found that the welfare loss of taxes is greater than the welfare gain of health subsidies in the benchmark economy. It's true for Australia and US. And therefore, the laissez-faire works better. So therefore, we want to look at how the policies can make a difference.
So according to your model, best would be to just let everybody take care of the business.
Sorry?
Like the prediction that arises from your benchmark comparison suggests that the best world would be we just let everybody take care of their business.
No.
No?
Because the social optimum provide the highest welfare. So now I want to look at how the public policies and private health insurance can achieve the social optimum and bring the highest welfare. to the economy. But if you look at the laissez-faire without any policy intervention works better than the benchmark economy. So I just want to highlight that the benchmark economies are very inefficient in that case.
Okay, yeah.
And what, and what is the benchmark economy doing at the moment?
They have this tax rate,
Which is observable from the data,
yeah,
basically.
yeah,
Ah,
all this,
yeah.
yeah.
In the US is the different in age, and in
Yeah.
Australia is.
They have very high tax, but the longevity is very low, investment rate is very low. All this lead to very high inefficiency loss. Okay,
But although not substantially better, right? Like,
Mm.
how do we interpret those magnitudes?
Which one?
Welfare gains.
the welfare gain, I
Benchmark
use,
versus,
yes, I compare the benchmark
yeah,
with the I economy. I can be laissez-faire, can be social optimum,
right.
can be public policy.
Yeah, but then compared to
Mm.
benchmark, the laissez-faire economy is 0.2% better.
Yes, yes,
It's
that's
not by
right.
a whole lot.
That's right.
Magnitudes are very small.
But welfare is not small.
No,
In terms
2%
of
is a
welfare,
lot.
yeah, it's a lot.
But
Yeah,
it's consumption equivalent.
yeah,
So
yeah, it's
basically,
not,
the
yeah,
each
yeah,
period
every
will receive
period,
2% more
I think
consumption.
it's a lot.
Is
It's
it
not.
2% or 0.2%?
I mean, I cannot see.
I don't know how to rank magnitudes, but
It's 0.21% every period. But for social optimum is 6.28% every period. For Australia, for US is 7.37%. It's very high every period, right? The welfare improvement.
This is 0. I
Hmm?
mean, this is 2.2 or 2%?
No,
This is
0.2%.
0.2%.
0.2%.
Okay, yeah.
Laissez-faire is
Usually
0.2%.
between 0 and 0.4, so, yeah.
I think it should be okay, right?
Yeah, yeah.
I mean,
still,
not too
I
small.
don't know how to interpret this.
Yeah. So let me skip all this. No time. Okay, now I look at the optimal health subsidies and income taxes. So suppose health subsidies are only financed by income taxes. What we need for Australia and US to achieve the social optimum is that the young age health subsidy should be higher than the current rate. The current rate is about 68%. So we need the young age health subsidies to be higher in Australia. Okay, and then the old age public health subsidy should be lower, should be 66% rather than 68%. And then the tax rate, that is the labor income tax for young workers, should be higher than the old age labor income tax for Australia, as I mentioned, because it is the young workers that receive more subsidies, public subsidies in Australia. Okay, but US is different. US is that the young workers, they receive more private health subsidies compared to the old workers, because the old workers receive 46% public health subsidies, right? So the young workers receive higher private health subsidies compared to the old workers that receive public health subsidies, but still the young workers should pay less labor income tax because they are not the one that benefit from the public health subsidies. So this is the difference. Okay. Okay, then if we add consumption tax to finance health subsidy, then of course adding consumption tax will reduce the distortionary income tax effect. So this overall is going to lead to lower income taxes and lower optimal health subsidies. Okay, so consumption tax can reduce the labor income tax, right? But we need the old age labor income tax to fall substantially, because if we include consumption tax, higher consumption tax is going to make children cheaper. So this is going to increase fertility. So we need to reduce old age labor income tax to increase the cost of raising a child. Okay, so therefore we need this old age labor income tax to fall substantially if we include the consumption tax for both the Australia and US case. So in this case, if we add consumption tax, then the old workers will receive a lot of this labor income subsidy in this case. I don't think I have time to go through all this sensitivity, but I will come to the conclusion. That is, I just want to highlight that the health externalities cause inefficiency losses in the laissez-faire which lead to lower welfare compared to the social optimum. And then appropriate public and private health subsidies or both, accompanied by appropriate taxes, can achieve the social optimum through age-specific rates of health subsidies and labor income taxes. And then if we look at the very extreme health policies, one is universal public health, one is universal employer-based health insurance, then we see that under the universal public health, the optimal labor income tax for all workers is higher, right? It means that financing optimal public health is very expensive compared to employer-based health insurance. And also, we find that the optimal labor income tax on young workers is greater than that on old workers if there is universal public health. Okay, as I say, under UPH, it is the young workers receive higher public health subsidies, so they need to pay higher taxes. And for the universal EHI, the optimal labor income tax on young workers is less than the old workers. Okay, so these are the difference. So the less extreme case will be introduce both public and the private health insurance, like what is currently done by the US. Okay, in that case, the optimal labor income tax for all workers will be higher than the universal employer-based health insurance, but should lower than the universal public health insurance, sit in the middle, the tax burden. Then the workers who receive the public health subsidy should pay more income taxes. So fairer in that case. Yeah, that's all.
Thank you very much.
But I welcome any other questions after the talk.
Yeah, no, definitely. I mean, maybe we have time for one question, and then we can just talk a little bit more outside. So, any question?
Yes.
Okay, so I was thinking that, so in a sense, it's moving the cost from one age group to another, or the older age group to the younger age group, or the younger age group to the older age group, right? So if it was not a dynastic family, then it would become kind of something like a competitive game between those two
Correct.
already.
Yes, correct.
Okay,
Yes, exactly. Yes. But here, because it's dynastic, then the young and the old, they don't really mind.
Okay.
Because if you I pay more, then you obtain more, then equal in that case.
No, because
they care about each other.
I just
If
feel
not,
like in reality, there's a bit of a competitive game going on between the younger and the older age in terms of like tax rates and all that kind of thing.
I agree. If you include this political economy into it, then there will be such a lobbying. For example, they will have this majority voting, then they will decide on this optimal tax rate differently. Yeah, definitely. Yes.
Maybe it would, I don't know how complicated it is, but it would be nice to see, for example, how the welfare gains are sensitive to this alpha, because I think the alpha is very important.
Oh, I do not do that.
For this trade-off, like between old and young. I mean, because
only do meal.
it's all about like intergenerational transfers, and I think the time discount factor is very important for this, no?
Alpha. Okay. Okay. I will take down the note. Alpha. Okay. It's easy to do that.
Any questions online?
Any question online, Adam? All good. Okay, so we finish here.
Okay. Thank you so much.
Please take picture to the QR code.
Survey.
Right, yeah, the survey.
For the survey.
Oh.
5-star.
Yeah. And we can go to desafíos para mi hija porque ahora cuando tenemos vaya.
You also talk.
Meet you.